Hello, and welcome to the latest in multiple myeloma, understanding promising treatment options in 2024. I'd like to introduce myself. I'm Stephanie Trong, the founder of The Patient Story. But more importantly, I also got a blood cancer diagnosis a few years ago, though mine was in non-Hodgkin lymphoma. Ultimately, though, I think we have so many shared experiences in what we're looking for, especially during a time as jarring and sometimes, beyond overwhelming, traumatizing as a cancer diagnosis. And so that is really what The Patient Story is all about, is we try to help both patients and their care partners, everyone in the support circle, navigate life after a cancer diagnosis. And we do this primarily through in-depth conversations with patients, care partners, and top cancer specialists like the ones you'll hear from today. First, I want to give special thanks to GSK for supporting our educational program. GSK's support helps us make programs like this one more available, especially as we've committed to providing free content for The Patient Story and the cancer communities. It is important to note that The Patient Story retains full editorial control of this entire independent educational program. On that note, it is very key, as a quick reminder, that this is not meant to be a substitute for medical advice. We do want you to be able to walk away with great questions to ask your medical team. The last item before we get to our discussion, we want your feedback on whether this program is helpful, what topics you'd like for us to cover and focus on in the future, what we could do better, what you'd like answers to. So please fill out our survey that will come to you when this program ends, and it will just take a couple of minutes. Now, to the fun part, to introduce tonight's patient moderators, Jack Aiello and Cindy Chmielewski, who will be guiding this conversation with our top myeloma specialists from this point forward. Jack and Cindy, I feel very lucky to have gotten to know you both and befriend you both virtually and also in person, and understand a lot of your background, have seen you out and about so much for so many years now, trying to help other patients and care partners figure so many of these questions out and just to be supportive. So first, thanks for what you do, but please share a little bit more about your own stories and that why, how you became such passionate advocates in this space.
Thanks, Stephanie. My name is Jack Aiello. I live in the San Francisco Bay Area and was diagnosed with multiple myeloma 29 years ago at the beginning of 1995. For me, and maybe for you, it started with a backache. Except for me, MRIs and X-rays didn't show anything wrong with my back, according to a back specialist I went to see. But I ended ended up having to take a blood test, and that blood test showed an elevated protein. And the back specialist said I likely have multiple myeloma. And that was the start for me of about 8 years of significant treatment. Back then, the average lifespan for myeloma with treatment was only 2 to 3 years. And so I was fortunate to respond to a third transplant, except that I used donor stem cells in that transplant after a couple of earlier transplants, and clinical trials didn't work for me. So I'm extremely appreciative to be alive 29 years later.
Hi, everyone. My name is Cindy Chmielewski, and I've been living with multiple myeloma since 2008. And what brought me to the doctor was probably this very debilitating back pain. And the back pain was so bad that it affected my job. I was having a hard time standing up to teach. I wasn't able to take my class on the playground for recess. I had to have other teachers do that. So I went to an orthopedic doctor. And unfortunately, I think my orthopedic doctor was unfamiliar with the symptoms of multiple myeloma because he diagnosed me with degenerative disc disease. And it took an additional 2 years to get the correct diagnosis of multiple myeloma. Since that time, I've had several treatments, and now I am doing very, very well. And I'm really excited about today's show is because I'm hearing all these new therapies that will be available to me if and when I relapse. Hello, everyone. Today I have the pleasure to introduce Dr. Fonseca, who is a hematologist-oncologist and Chief Innovation Officer with the Mayo Clinic, with a special interest in multiple myeloma. He also participates and leads clinical trials that have led to the approval of various drugs for the treatment of myeloma. Welcome, Dr. Fonseca. And before we start, I would like to know what drew you to multiple myeloma and what drives you most to continue work in helping myeloma patients.
Well, thank you, Cindy. First of all, it's great seeing you and Jack and Dr. Ball as well, too. It's just wonderful to be here. Happy New Year to everyone. I really got into myeloma. There's a combination of a little bit of luck, but my luck was mainly because I had great mentors. Dr. Phil Gripe, the late Dr. Gripe, was a wonderful influence in my life. I wanted to do lymphoma, but he kind of steered me into the right path, which was myeloma. That is without knowing what would happen. I mean, those were the days of melphalan and prednisone. And which really links exactly to what you're telling me, what drives me now. I think we are, again, very fortunate to be living through this times that so many things are happening for the treatment of myeloma. One of my colleagues, Dr. Mesa, told me a few years back, you folks in myeloma are either a drug away or a combination away from being able to cure a significant fraction of patients. And I think we're in that process. We're shuffling the pieces in the table, but I think we're there. So that keeps us going, of course, every day.
And it's my privilege to introduce Dr. Susan Ball, who's a hematologist-oncologist with the University of Alabama at Birmingham, with a special interest in myeloma and CAR T therapies. In fact, at a recent American Society of Hematology meeting, I was fortunate to see Dr. Ball as primary investigator present phase 1 findings for the clinical trial of BMS 986393, which is a GPRC5D CAR T. Dr. Ball, what drew you to myeloma and what drives you most to continue your work to help patients?
So thank you so much for having me here. It's really a pleasure to be here today with all of you and get to do this program. Personally, to me, I think myeloma was always very exciting. When I started my fellowship was the year that we saw the first results from daratumumab come about. And I think the excitement in the field and the possibility of cure, and really one thing that drives me most, I would say, is because our patients live for so long and do so well, is the meaningful relationships that you can continue to build is really what really brought me into the myeloma space. And I'm so delighted to be able to work with a great group here and across the country. The myeloma community is strong, and we forge onward in our path to curing this condition.
Nice. Thank you very much. Cindy?
Yes, Dr. Wall, we're very happy to have you today, but let's start just by going over briefly what is multiple myeloma and what are some of the first signs and symptoms?
Of course. So multiple myeloma is a plasma cell disorder. So it's a disorder of plasma cells that have become cancerous. So within our body and our immune system and our blood system, we have white cells, red cells, and platelets. White cells fight infection. Red cells carry oxygen. Platelets stop us from bleeding. And one of the types of white cells that helps us fight infection is the plasma cell. So the plasma cell is responsible for making antibodies that normally helps us fight infection. Sometimes when these plasma cells go awry and become cancerous, they can crowd out the bone marrow, resulting in symptoms such as elevated calcium levels, bone breakage, bone damage. It can affect our kidney function, causing renal dysfunction. It can also cause low blood counts because of crowding out of the marrow. And certainly because of it's a part of the immune system and its job is to prevent us from, infections, oftentimes patients can present with recurrent infections as a presenting feature as well. So patients can come to us really from any of these avenues, and that's what makes it interesting is we see patients who are simply diagnosed because they had an astute primary care physician who picked up on a protein gap, and we have patients presenting at the other end of the spectrum with the plethora of all symptoms that we know as crab symptoms, and presenting with very disabling features. So really it's a very heterogeneous disease, certainly in terms of presentation and how people do overall.
Thank you so much for that little summary. And Dr. Fonseca, we're lucky now. There's so many treatments available. When I was diagnosed back in 2008, the treatment arsenal was not nearly as filled as it is now. So with all these treatments that are now available, what are some of the considerations you think about when choosing treatments for different groups, like transplant eligible versus transplant ineligible and newly diagnosed and high risk? Like, what goes through your mind?
Thank you, Cindy. That's that's the essence of everything we do in the practice, right? All of those considerations, and then how do we present them and share them with patients as options for their treatments. When we started seeing all these drugs come forward and being approved, my first reaction, and probably that would be of anyone, would be, boy, this is going to get complicated. How are we going to choose? And we have all these treatments, and maybe my appointments are going to have to be 2 hours long because I have to present everything to patients. But as it's true with everything else in medicine, the availability of additional information has allowed us to narrow down what are the best options for patients, such that even though we have many more drugs, we still have 1, 2, or 3 options that are probably the best for a given step for a person. So that has allowed us to work more on our messaging and the rationale of what we do. I think the considerations you mentioned are critical. So we always want to look at, first of all, the patient as a person, and as a person with their preferences and what their goals are, as well as some of the issues related to their own health, what we physicians would call the comorbidities of the patient. Now, one of the critical aspects for that, and one we can't modify, I know many wish we could, is our age. Age is a major determinant on how well you're going to be able to tolerate treatment or not. There are some treatments that become quite a bit toxic as we take them later on in life. A great example of this has been the stem cell transplant. So we as physicians and clinical teams have to tailor our approach to patients as we start proposing the various treatments. The second consideration is what you said, is whether the patient is newly diagnosed or whether this is someone who unfortunately has now myeloma that is coming back, what we would call recurrent myeloma. And if we think about that, then we say, okay, which stage is this? Is this an early recurrence, or is this someone who has already received 3 or 4 prior lines of therapy? Then we bring other factors that I think it's important that patients know about and we discuss with them, such as what we would call the biology. We like to test the myeloma cells for the genetic makeup. By the way, I'm going to put in the comment here because this can easily get confused. When we talk about genetics in myeloma, we're mostly talking about the changes that occur in the myeloma cells, not the genetics that a person may have in the rest of their body. And very importantly, not genetic things that are passed on from generation to generation. These are just the changes that occur in those myeloma cells. But those are things that play into our decision-making process. Some patients have markers that would make us more concerned, something we call high-risk myeloma. And with that in mind, we put together treatment plans that we propose for our patients. I think we're moving forward with a more unified approach to goals. If you go back 15 years, or certainly 1995, Jack, you were mentioning, our goal was control. Our goal was, can we do something that will put the myeloma under some control at bay that would allow us to gain time? I think many of us feel like the pendulum has swung completely the other direction. I think many individuals, myself included, think that we should aim to eradicate all myeloma cells and ultimately produce cures for patients. So I think how you sort of phrase that and plan for that becomes important. And behind that, there's a whole set of other principles. But probably I'll stop at that point and say those are some of the overriding things we think about, but always starting with a person, which is that patient.
Thanks so much, Dr. Fonseca.
So, Dr. Ball, when I introduced you, I said I saw a presentation at the American Society of Hematology meeting, which was this past December. Can you explain the importance of ASH, and then what, from your standpoint, were the biggest takeaways from this year's ASH?
Absolutely. So the ASH meeting, or the Annual Society of Hematology, the American Society of Hematology meeting is a key event for hematologists in the year, and it's really where we expect to see some of the latest and greatest of the science and all the discoveries and innovation that's occurring within the field. And it's a one-stop shop where we get to see some of the best data. So certainly it's a very looked forward to event in the community. This ASH was no different. In fact, we were lucky to have two major presentations at the meeting, including a plenary session where we saw results from the ISKIA trial, as well as a late-breaking session where we saw results from the Perseus trial. So I'll break it down, and I'll start by talking a little bit about the Perseus study. This was perhaps one of the most awaited trials, in the sense that this was a randomized phase 3 trial evaluating a quadruplet regimen of daratumumab, bortezomib, lenalidomide, and dexamethasone versus the same combination without daratumumab in patients with newly diagnosed transplant-eligible multiple myeloma. And for many in the field, we have moved towards using these quadruplets based on an earlier phase 2 randomized Griffin trial. But this was practice affirming and perhaps practice changing for a small proportion of patients in the community. What this trial did was take patients who are transplant eligible, so those patients who are fit in the European and Australian countries, which is where this was predominantly performed, and patients were randomized into receiving 4 drugs versus 3 drugs that I just mentioned, followed by stem cell transplant, and then a doublet maintenance following consolidation therapy with the same regimen. And what we saw was overall that with a close to 4-year follow-up, that patients who received this 4-drug regimen did a lot better and had longer progression-free survival at the 4-year time point. And patients had a very deep response with this regimen, achieving measurable residual disease negativity, both using very sensitive markers and sustaining over prolonged periods of time, which has been shown to really be hopefully a surrogate for improved patient outcomes overall. So this was, like I mentioned, within the US, many in the field have already taken up practice of adopting this 4-drug regimen based on the prior Griffin study. But I think this was confirming and affirming for those of us who doing that, and then practice changing for those who were still using the triplet combination. And I think this was perhaps one of the most exciting things to come out of this trial, among other things.
So that's fantastic. And Dr. Fonseca, what about you? What can you describe maybe an outcome you saw from ASH, which was so important to the myeloma community?
So it's a wonderful time for us, and more so given the progress we're seeing in myeloma. But I think the fact that we have now very strong data for what needs to be done in frontline is very important for patients. I think that at this moment, It's beyond any doubt that we need to use the best treatments up front. And for now, that means the incorporation of this monoclonal antibodies, the CD38 antibodies. Dr. Ball mentioned, of course, the use of daratumumab. We also have the similar molecule isatuximab. But the clinical trials really point to outstanding results which could not be seen ever before with the treatment of myeloma. In fact, the results are so good that they're now are going to start challenging some of our assumptions. So if you remember, almost 10 years ago now, we had the meta-analysis for the maintenance strategy for myeloma, where patients go through that induction, they get the transplant, and they're placed with maintenance. But Dr. Costa has pointed out repeatedly that those maintenance studies were done where we could achieve a complete response in about 30 to 40% of patients, minimal of this MRD negativity, and sometimes patients were getting 2 drugs as induction. So one would say, well, no surprise that more treatment was effective, whether we call it maintenance or consolidation is just semantics. And now we're getting to the point that many patients have a complete response, and we have studies that are showing, and depending how you measure and the threshold, that somewhere between 60 and 80% of patients can get into minimal residual disease. So we're starting to ask questions. Do you even need maintenance in those patients? I don't claim in any way that we have the answers, but it just reflects how fast things are moving forward. And breaking it down, as Dr. Ball did, I think is critical. For some people, we were practicing this. But for other people, either they need this for regulatory purposes across the globe, or their reading of the medical literature is such that they want to have that phase 3 trial before they change clinical practice. I think right now it would be a rare patient that should not be offered induction therapy with something as we were describing. And in fact, a lot of things are getting simplified. Just yesterday in a conversation with colleagues, I was thinking I could put out a message on Twitter and say, the treatment of myeloma should always start with something like daratumumab, lenalidomide, and dexamethasone. And then the secondary question is whether the patient needs to get a proteasome inhibitor like bortezomib or Velcade as known by patients, or carfilzomib, Kyprolis, and whether they need to get a transplant. But then things get simplified because the best players rise to the very top of what we're doing. So I'm excited for what this means for patients.
I completely agree with Dr. Fonseca. I feel like some of the things that are almost becoming cleaner as we go. I remember this discussion about 3 years ago where everybody wanted to know, would you give DARA to a transplant eligible patient? Would you give DARA to, I think the answer is becoming clearer and clearer and clearer that, you want to use your best drugs up front and really make that first cut your deepest. And I think I answered recently when somebody asked me, is there a patient you would not give DARA? And I said, I don't know who that would be, because it's such a well-tolerated, effective therapy that now I'm thinking more, like Dr. Fonseca said, about which of the other agents you could potentially get rid of or improve upon, rather than the DARA aspect of it. So I think the answers are becoming cleaner.
Yeah, that's great. Dr. Fonseca, one of the important trials, and Dr. Ball referred to it earlier as having been given special recognition at ASH as a plenary session, was the ISKIA clinical trial, which compared carfilzomib, Revlimid, and Dex, adding isatuximab to it or not to it as frontline therapy. Isatuximab is like daratumumab in that they're both CD38 monoclonal antibodies. So this is for transplant eligible patients. It was another 4-drug trial. Can you talk a little bit about that, since it was given plenary status at ASH?
Yes, I mean, the reason something is given that plenary status is when the reviewers and the reviewing committee feels that there's something there that is of such high value that, reaches the highest standards of evidence, or that even potentially becomes immediately practice changing. And I think this particular clinical trial was one more point in that direction, where they, start looking at the response rate and the MRD negativity rate for those patients. For those in our audience who may not be familiar, MRD negativity refers to the term of measurable residual disease or minimal residual disease, which is nothing different than saying we have better markers to assess the depth of a response. That's all it is. And that is through mechanisms such as genetic testing. And it's becoming increasingly clear, and I would argue now very well documented, that achieving that status where you can no longer find measurable disease. And this is with tools that are very sensitive. Some of them can go at the level of detecting one cell out of a million, that achieving that becomes a harbinger of great outcomes for patients, of durable responses, and ultimately improvements in the various metrics that we call survival. So and that trial shows that, and it's very interesting to me for a couple of reasons. One is this is a different antibody, so this is a different molecule than daratumumab, but the presumption has been by those in the field that we should see similar results, that even these antibodies that they carry nothing of what we call a payload. It's just, we use the word, they're a naked antibody, meaning they just go and bind to those cells, and by doing that, they unleash kind of our immune response to those cells. They're able to kill more cells, and we know that because the responses are better and the MRD is better. In that particular trial, we have to wait for a little bit longer to see what the outcomes will be over time on those metrics that people hear about, like progression-free survival and overall survival. But all the indicators as well are, given what I said about MRD, that this will be a very useful approach for the treatment of patients. Now, the second aspect, which I find interesting, going back to our conversation, everyone should get a CD38, lenalidomide, and dexamethasone, at least for the time being. But then the question is, what about these drugs that we call proteasome inhibitors? And in this particular trial, they use carfilzomib. And for me, that's very interesting because that's what I do in my clinical practice. And when we make decisions in our clinical practice, there's trade-offs of the drugs we use. Carfilzomib is a sister medication to bortezomib. They're both proteasome inhibitors, but there's different toxicities that each one of them has. There's no clear-cut evidence that one is better than the other, although some have a remaining hypothesis, I would call it, myself included, that it's more effective. But I just don't like to see the enduring toxicity that occurs with some of the other drugs like bortezomib. So that's where we will be spending our time talking about those type of drugs. Should we use bortezomib? Should we use carfilzomib? If any patient is hearing this, I think both are standard of care, excellent treatment for you. So there's nuances of why we choose one or the other. And again, the second question will be transplant too as well. Because if you have these regimens that are able to make patients have such a great response that they become quote unquote MRD negative, then the question of, I already mentioned maintenance, but the question will come forward, do you even need transplant? For patients hearing this, I'm not saying we're ready to say we can dispense with transplant, but the data continues to show that deep responses, no matter how you get there, will result in better outcomes. So maybe some patients will elect to say, I'm going to collect cells and maybe think about a transplant later and so forth. That's a very long conversation, a nuanced conversation, but reflection just of the progress we're making with this type of combinations.
Very good. Dr. Ball, you were saying that things are becoming cleaner, but now we're thinking 4 drugs up front, but which 4 drugs? I think Dr. Fonseca was alluding to it, but are there any considerations that you take into whether your PI is going to be Velcade or Kyprolis, or what CD38 monoclonal antibody to use? Like, what goes through your mind now that you're picking 4 drugs?
Absolutely. So, I think that as Dr. Fonseca already mentioned too, I think the patient in front of you helps determine some of that. So, as you know, daratumumab versus isatuximab, these are both anti-CD38 monoclonal antibodies. They are both very effective drugs. However, one is subcutaneous, so administration's a little bit easier with the Darzalex or daratumumab, which is given as a short injection underneath the skin. The other one requires an IV. So for now, at least, until we have the subcutaneous version for isatuximab, that does reduce chair time and patient convenience very much, I do believe. In terms of which proteasome inhibitor is the right choice, I think that some of that depends on the patient profile and what are some of their comorbidities that they already have. What is their age, for example? With bortezomib, we're aware that the risk of peripheral neuropathy is significant and can be quite disabling even at lower grades. However, with carfilzomib, we have seen cardiac and renal toxicities, and even more than just objective data. A lot of people complain of subjective dyspnea, subjective shortness of breath, things that can make it challenging for them to feel good on their treatments. So young, very robust, and perhaps high-risk patients are best stratified into the carfilzomib arms, and older patients, depending on their fitness, would then get either no PI or proteasome inhibitor or a bortezomib based option. So that's how we sort of think through when the patient's in front of us. But I feel like that part is rather individualized without any clear data of one being overly more efficacious than the other, at least based on the data that we do have in front of us.
Are there any groups of patients or any particular patients that you would not give the quad to? You would probably go back to triplet therapy or maybe even doublets.
I think incorporating, frailty assessment and assessment of the patient's overall performance status going beyond, the eyeball test that we do is going to be critical in determining who is really not fit to receive a quad. I think in those cases where there's concerns about use of a proteasome inhibitor, particularly bortezomib, due to underlying diabetes or other such comorbidities, or the patient's older and you're concerned about cardiopulmonary toxicity with carfilzomib, I think in those cases, as Dr. Fonseca also mentioned, daratumumab with lenalidomide and dexamethasone is an excellent option with high level evidence of benefit. And the very old, I would say, patients who are in their high 80s, even 90s, I think in those patients I would consider a doublet. But what's interesting is that the doublet I would consider there would be a Dara-Dex type combination or even Dara single agent type combination, because IMiDs require hematopoietic monitoring or blood work closely to be checked for low blood counts, and certainly the proteasome inhibitors carry all the concerns that we just mentioned. So in those patients, the very elderly, very frail, daratumumab is exceedingly both efficacious and quite safe as long as you provide them with appropriate antibiotic coverage and close monitoring, vaccination, and perhaps even IVIG use to protect them from infections.
Good. And Dr. Fonseca, follow up, do you have anything to add to what Dr. Ball said? And also, what about maintenance? Are you seeing single drug, double drug maintenance? Can you just touch about that?
Yes, no, thank you. I think everything was very eloquently said for what we're considering now as we think about this treatments up front. I think one of the points that Dr. Ball made, I want to emphasize. If you ask me 2 years ago, what would you do with a frail patient who has newly diagnosed myeloma, my response would have been lenalidomide and dexamethasone. But we saw with the analysis, subset analysis in the context of the clinical trial MAIA, that the addition of daratumumab significantly improved outcomes for these patients. And I'm glad we have the data because, we would be at significant risk of shortchanging patients in the line of thinking of beneficence. Let's be kind, use mild treatments, but it turns out that the survival numbers are not as good. Now, whenever we add a drug, we have to think, I'm going to add toxicity, but the reality is these antibodies are incredibly, incredibly well tolerated. It's different to propose adding carfilzomib or not versus adding daratumumab. So today, I would say most patients, the vast majority of patients, even if they're frail, they should get something like daratumumab up front. Now, to your second question, maintenance, that's really, really interesting. I'm hoping, and I think we're going to get there soon, and studies like the ones done by the group of Dr. Ball as well, too, that are using this adapted strategies to look at, can we stop therapy, naturally lead to the next question, which is, does everyone need maintenance? And I don't know what the answer to that is yet, but I know that the question is very relevant. And I think we're going to get to the point that we're going to think of maintenance like people think of like adjuvant therapy for breast cancer. I think many in the audience would be familiar. You complete surgery, they look at the lymph nodes, they look at the genetic makeup of breast cancer, and they say, you need chemotherapy or you don't. I think as we incorporate our genetic knowledge, the status of response after induction plus or minus transplant, then we're going to ask those questions. Does everyone need maintenance? And I think it's going to diverge a little bit more to the extremes. There's going to be greater contrast. What I mean by that is as follows. I think patients that are able to complete induction therapy and let's say have a transplant and have MRD negativity 10 to the minus 6, and maybe they have standard risk genetic factors, it's going to be hard to prove on some of them that there would be added benefit of maintenance, maybe. And if so, hopefully something that's better tolerated, because as we know, lenalidomide has significant burden toxicities for patients. On the other hand, if the patient has residual disease, I don't think there's good enough reason to just say, well, that's what we do. That's standard. I'm just going to cross my fingers and maybe get a rabbit's paw wishing me luck that this is not going to come back. I think those are patients that we're going to provide additional treatment for no other reason than to try to get rid of all residual myeloma cells. What I say, quote unquote, let's finish the job. So I think that's where we're going to go with maintenance. So I don't foresee that maintenance as we have it right now, which was everyone gets lenalidomide, you get it until you can tolerate it and hopefully not major side effects or no disease progression. I think that has to change.
Very good.
And I couldn't agree more with Dr. Fonseca. I think we certainly share our opinions regarding the use of measurable residual disease, and it's really superseded and become the single most important prognostic marker, one that is not just defined when you're first diagnosed, because it's actually not defined at all when you're first diagnosed, but rather comes into play after therapy. And if you can eradicate evidence of disease, you can improve your outcomes significantly, whether you're starting out as a high-risk patient or a standard-risk patient. I think getting to that milestone and maintaining, more importantly, that milestone can really improve outcomes. So I think maintenance as we know it today will soon cease to exist, hopefully, but mostly because we're either giving them more therapy, getting them where they need to be, or they've done so well because of the excellent therapies we have that we don't need to continue suboptimal treatments that have other toxicities and risks associated with them.
I have so many more questions I would like to ask, but I'm going to give it back to Jack so Jack could get his questions in.
So, as effective as the treatments are, myeloma still often comes back. And one of the exciting new treatments going forward is this CAR T therapy. So I guess I would first ask Dr. Ball, can you explain what CAR T therapy is, maybe in conjunction with the BMS CAR T that you presented at ASH?
Absolutely. Thank you, Jack. So CAR T-cell therapy stands for chimeric antigen receptor T-cell therapies. Within our bodies, as we had just talked about, there are immune cells, white cells. One of those subtype of cells are T cells, which are normally, working to keep our cancers in check. The thought is that, these T cells are not working as well as they need to be, and the cancer itself is finding mechanisms to evade our immune system, which is what results in disease relapse. And this is really a revolutionary therapy where, at least when we talk about autologous CAR T cells, meaning we take out a patient's own T cells by apheresis procedure, very similar to a procedure that patients go through when they do stem cell collection. So with that process, we obtain patients' T cells, and then in the lab, we essentially teach these cells using a viral vector to express these new antigens on their surface or receptors on their surface that can target cancer antigens within a patient's body. And thereafter, we provide the patients with lymphodepletion chemotherapy, which is essentially chemotherapy that's given to reduce the number of T cells which are within the patient's body, and then infuse these chimeric antigen receptor T cells, which can then go in and interact with the antigen using their CAR receptor and cause cancer killing or tumor death. So this has been shown to be a very effective modality, particularly in patients who would previously not have very good treatment option after they've been through the three main pillars of therapy, like the CD38 monoclonal antibodies, immunomodulatory agents, and proteasome inhibitors. And these patients previously had dismal outcome measured in single-digit months. And now, with these therapies, they're living longer and are having excellent responses, including several that are MRD negative, even in this late-line disease setting. So at this time, there is FDA approval for two chimeric antigen receptor therapies in myeloma that target the B-cell maturation antigen. This is an antigen which is present on the surface of plasma cells with plasma cells in general and more on the surface of malignant plasma cells, so the cancer cells. And using this target, we have seen very impressive responses, up to 98% overall responses with one of the FDA-approved agents known as cilta-cel or Carvykti. And so this is shown to be an effective avenue. What we presented at the ASH meeting this year is a chimeric antigen receptor T-cell therapy, which is targeting a different antigen known as the GPRC5D antigen. And this antigen is also one that is expressed preferentially on the surface of these cancer cells and has limited expression across normal tissues, although we do see some expression on tissues such as hard keratinized tissues. We see it on skin, we see it on nail beds, we see it in the hair follicles, and we see some typical side effects, including dysgeusia or with treatments that target this therapy. So in what we have shown as overall GPRC5D has been shown to be a promising therapeutic target in myeloma. We already have a different immune strategy that's working against this and is FDA approved. And so in this phase 1 study, we evaluated a CAR T cell which is targeting GPRC5D on patients with relapsed myeloma. And what we saw is that in a heavily pretreated patient population who have received a median of 5 prior lines of therapy, that this was associated with deep responses overall in about 73 patients who were efficacy evaluable, meaning were evaluable for response assessment. We saw that 88% of the patients had a response, and for the first time, we shared the recommended phase 2, which is the dose that's going to be moving forward. It was determined at about 150 million CAR T cells. And what was encouraging was that the response rate for this RP2D or recommended phase 2 dose was 91%. And at that dose level, we saw low-grade CRS, so no patient had grade 3 or higher CRS at this level. There were no cases of other serious toxicities such as macrophage activation syndrome, etc. And this dose was efficacious. So far, the follow-up for this dose cohort is relatively short, and so we don't know what is going to be the long-term progression-free survival and overall survival, but the responses are deep, and we need to follow the study longer to understand what is going to be the more important and relevant outcomes like progression-free survival and overall survival.
Thank you. Dr. Fonseca, Dr. Ball mentioned that there are actually a couple of approved CAR Ts available for patients now, except the fact that they require 4+ lines of prior therapy. So there are trials and announcement of results from those trials like CARTITUDE-4 and KarMMa-3 that are testing these same CAR T therapy in earlier lines of treatment. Can you talk about the results of them, but tailor your answer to kind of patients' quality of life?
Thank you. Thank you very much, Jack. So you stole my thunder because I think that is probably the key aspect of all of this. And as you mentioned, there's 2 trials, the CARTITUDE-4 and the KarMMa-3, that are looking at this earlier on. KarMMa-3 with 2 to 4 prior lines of therapy, and CARTITUDE-4 with 1 to 3. And what they really explored is if they work well downstream, as it's true for every single myeloma drug, we cannot keep bringing them towards the forefront. And the results are quite remarkable. I think many of you saw the presentations and ultimately the publication of the CARTITUDE-4, which was presented at ASCO as well as ISKIA and published in the New England Journal. And what we're seeing is this treatment can provide very durable responses that can go on for years for some patients. And then, of course, the natural question is, well, how does this compare to other things? We have effective treatments that can work very well in someone who's experiencing a first relapse, such as could be a combination of daratumumab, carfilzomib, and dexamethasone, or isatuximab, carfilzomib, and dexamethasone. But the one big advantage that something like a CAR T has is that it's quote unquote one and done. And we're seeing patients that are reporting very, very high levels of quality of life and making statements like, I haven't felt this well in such a long time. And it's not necessarily because a CAR T gives you superpowers. It just gets rid of all of the side effects that come with treatment. Because even the most benign of treatments involves, logistics, medications, blood draws, what we would call the venipunctures, and then some of them have the side effects that come from the chemicals or the biologics that are used as side effects. And even in the best case scenario, it still is, it's just something that the patient has to do. And the idea that you're done, and then all that needs to be done is just occasional labs to monitor becomes very appealing. So I think that's probably going to be the number one driver. Of course, we're very excited. We're hoping to see these treatments have very, very long-lasting, benefits for some patients. But even if they were not for some, I think the ability to be treatment-free would be just beautiful. And our colleague, Dr. Amrita Krishnan from City of Hope, I always quote her on this. She said, one of the unmet needs in myeloma is to stop therapy. So even if it's temporary, for some, hopefully more durable, this would be a way to achieve that.
I have patients in my support group that say exactly what you say. Some are without treatment 3 years after their CAR T, but even those that may have relapsed sooner, like 6 months or 10 months, say they would do it all over again just because they had that drug-free period that they were so appreciative of. But that said, Dr. Fonseca, I want to ask you another question that's concerning me about a specific CAR T side effects having to do with secondary myeloid cancers like AML and MDS. And I'm hearing some concerns about that and wonder what your take is on what's out there.
Sure. Well, thank you. First of all, I'm going to say that we don't completely understand this, and there are many other factors that may come into play. But as you know, the FDA recently put an announcement about this, that a fraction of patients, up to 10% in the series that was reported, could develop secondary myeloid malignancy. So for our audience, these are the cells that produce your regular white cells. And the conditions that follow from that are either leukemia, acute leukemia, or the preceding stage, which we call myelodysplasia, which is as well concerning to us as physicians. There are many reasons why this could be nothing more than the reflection of patients living longer and patients who have had exposure before to a number of agents and drugs that are known clearly to cause this. And this could include things as the melphalan that is used from the stem cell transplant, but also some of the drugs that are used to do the priming of the body as you're going to get the CAR T cells, including the fludarabine. On the other hand, there might be other reasons why this actually could be linked to the CAR Ts, and I think you're going to hear more about this as people do the research. So, for instance, we know that patients with CAR T, after they have the CAR T, can have sometimes prolonged periods of low blood counts, and no one really knows why. Because the CAR Ts are supposed to target, for instance, in the case of BCMA is predominantly expressed in B cells, not in this myeloid cells. So how come we have myelosuppression? We don't know for sure. But if you have that, then there's a lot of hypotheses that can come forward. Does that create an environment that maybe selects for clones that are going to do this? Does that create an inflammatory situation that maybe allows for progression of some of those pre-malignant clones? Our audience is familiar with the term MGUS, right? So as you know, we have myeloma and you have MGUS, and this is a prototype of this stepwise progression. It turns out there's a similar thing that happens for myeloid cells, that there's something called CHIP, and it turns out it's very common. It's just one of the things that happens to all of us in life as we age. You develop this kind of pre-malignant states, and CHIP is very common, can be seen in up to 40% of people. So the question is, there's something that the CAR Ts are doing that maybe makes some of this CHIP grow more, or the CHIP cells be favored? We don't know, but these are important questions. But practically speaking, for our audience, as of now, the threat is much greater from unattended myeloma. So while we want to have perfect treatments with no side effects and those things, I still would say that for someone who's considering a CAR T, it's much better to get the CAR T than not, despite these considerations.
Well, they have other options. Those are bispecific antibodies, so I'll turn it back over to Cindy.
Okay, so let's put this new hat on. Bispecific antibodies. Dr. Ball, since you did such a good job explaining what CAR T cells are, bispecific antibodies, I hear patients sometimes referring to them as off-the-shelf CAR Ts, and I know they're not. Can you kind of explain the difference between a bispecific antibody and a CAR T?
Thank you, Cindy. So, bispecific antibodies are antibody fragments. So I usually think of them as a little Y-shaped linker. That's how I typically describe them to my patients. So this is an antibody that has two prongs, if you will. On the one hand, it uses the CD3 molecule to catch the T cell. And on the other hand, it has a antigen receptor for one of the myeloma targets. Currently, we have bispecific antibodies that are targeting cancer cells using the same antigens that we talked about for CAR T cell therapy, such as B cell maturation antigen or GPRC5D. So they target the cancer cell using one of these antigens and then bring the two close so that cancer cell killing can occur by the immune system. So one of the best parts about bispecific antibodies is the fact that you don't have this lag time or delay that comes with manufacturing associated with autologous or self-generated CAR T cells. And these therapies are off the shelf, if you will. They utilize the patient's own T cells, bring them close to the cancer cells, and result in cancer cell killing. So in patients oftentimes where we don't have the time or the manufacturing capability or the slot allocation, or all of those patients who are not necessarily being treated at a large center with CAR T cell capabilities, this provides an avenue to use new immune treatments and immunotherapies for a wider range of patients. And I think it has a potential to reach many more patients given the current state of affairs, at least in 2023 and 2024, and so presents a very exciting option for our patients.
Good description. Dr. Fonseca, were there any major updates that we should know about out of ASH on bispecifics?
Yes. We had a number of updates, some of the longer term outcomes, and then some of the studies that are looking at bispecifics in various combinations, including with some of the traditional agents. I think I'm very interested to see how this actually plays out, because what we're seeing is that the bispecifics, first of all, are very active. Some could argue don't have as of yet the same horsepower as something like some of the CAR Ts. So, many of us are thinking of using them down the line. But some of them in combination are incredibly, incredibly active. So there's clinical trials that are looking at bispecifics, for instance, in combination with things like pomalidomide. Bispecifics between themselves. So there's a trial that combines talquetamab and teclistamab, the redirect trial. Bispecifics with daratumumab in combination. And just as excitingly, we have new constructs that are being developed. So we saw a presentation about something that is called a trispecific. So instead of just having one site that a bispecific can attach, there's bispecifics that could attach to two different anchor points that these myeloma cells have. Now, I particularly are interested in the bispecifics because I think the possibility that many more patients be treated is there for bispecifics than for CAR Ts, because CAR Ts require the centers of excellence, the referral patterns, and there's the wait times for the cell production. Whereas with the bispecifics, they're quote unquote off the shelf. So I think it's going to take some time, and people have to become familiarized with this. But in the future, we'll see community hospitals and mid-sized hospitals administering these bispecifics, which in my mind is wonderful because many more patients will derive benefit of these types of therapy. And for those in the audience too as well, you should know this is just the beginning of this new era in cancer treatment, because in fact, all of what we call the solid tumors are being explored for bispecifics. So things like lung cancer might be treated with things like this. So I think oncologists in the future will need to be certainly facile and comfortable with the use of bispecific antibodies.
Good. Dr. Ball, we said that CAR T cell therapy is a one and done type therapy, at least now. What about these bispecifics? Are they one and done? Are they weekly? Are they monthly? Do they go on forever? Can you talk a little bit about the dosing and schedule?
Yes, I'm happy to. So currently, there are actually three FDA-approved bispecific antibodies that are on the market. So we have two agents that are targeting BCMA. These are teclistamab and elranatamab. Both are bispecific antibodies targeting B-cell maturation antigen. These are drugs that are typically given as of right now, as their indication stands, on an ongoing basis until disease progression or unacceptable toxicity. Typically, these start out in the hospital with a small portion of inpatient hospitalization where patients receive step-up dosing to minimize the risk of certain side effects. And afterwards, they go on to weekly or every 2-week format. And in this fashion, they go on until the patients continue to respond or come off due to side effects. However, patients take about a median of a little over a month to respond to these agents and up to about 6 months to get into a complete response. And often these responses are very deep. And in those patients that come off because of side effects, we see that some of these patients are able to maintain their response for years without the treatment. So there's a lot of push about fixed duration of therapy, and one of the greatest reasons beyond patients having to come to the hospital or clinic and sort of the treatment and travel burden is the side effect profile. So these B-cell maturation antigen directed bispecific antibodies have a lot of infection risks. So 70+% of patients get infections, and 40 to 50% of these can often be grade 3 or higher, which can be quite serious. So these infection risks, particularly oftentimes infection with unusual things that we don't typically see in myeloma patients, has also enhanced some of our concerns about using these agents on a prolonged basis in patients whose disease may be controlled. So multiple factors are at play, and therefore there's a lot of interest in studying fixed duration therapy of these agents to really tailor it to a patient's response and then be able to discontinue these therapies once they're responding to optimize their risk and benefit profiles.
And that's good to hear. Now, Dr. Fonseca, we talked about CAR T cells. We talked about bispecific antibodies. Let's go with antibody-drug conjugates. I think we had one that was approved through accelerated approval, then it was taken off the market for about, but now it may be back. Could you talk a little bit about the story of Blenrep?
Yes, no, thank you for the question, Cindy. So for our audiences, ADCs type antibodies are antibodies that carry kind of a payload. So there's usually a chemical entity that is attached to an antibody. And in general, what happens, the antibodies they bind to the cell surface and then they go inside the cell because they're engulfed, they're eaten into the cell, where they release whatever that chemical structure. So one of those antigens is this one, belantamab, which in fact, when it first started, I mean, it showed very, very high rates of response, actually quite promising responses, and went through regulatory approval for a fast track approval. Unfortunately, there had to be a confirmatory phase 3 trial that did not meet the endpoint. So that means that the data for the trial would not support the complete approval by the FDA. So the product has been since withdrawn from the market, available on a compassionate basis. But this is a highly active compound. It does come with some baggage. One of the main baggage is toxicity to the eyes. So it's something we call keratopathy, and that's inflammation of the outside layer of the eye, the cornea. But I think as we're learning how to use it and better doses, that has been a little bit better tolerated. It's not to say it doesn't exist, but people are understanding better how to use this. And we just learned about 2 trials that are very exciting. One of them is where this was compared to daratumumab. So it was the DREAM7 trial. I think we're going to hear about this soon at the ASKO update. We're told the trial is positive, meaning there's favorable effects of the belantamab. So we'll have to see what the actual numbers show. And then there's another one that was just recently published called the Algonquin clinical trial, which is a combination of belantamab, pomalidomide, and dexamethasone, which really has pretty interesting results. The question is going to be, how do we time all of this? Because belantamab does target BCMA as well too. So that means it could be in competition with bispecifics and CAR Ts. And we know when we use several agents that target the same anchor, there is a possibility that you could develop resistance to that. So we'll have to wait and see. But going back to my previous comments about the bispecifics too, ADCs are one of the hottest things right now in biotech and development for solid tumors as well too. So I was hearing from people who were at one of those recent conferences at JP Morgan that a lot of companies are interested in them. So I think we'll see a comeback of ADCs in myeloma and in other diseases as well too.
Okay, so if you had to look into that crystal ball, do you think Blenrep will be coming back on the market?
It's interesting. I think it will depends on, and I'm not currently up to date on what the regulatory pathway will be for that to actually occur, but the results are exciting. The question is, how will this compete or compare to some of the other things that I'm mentioning with bispecifics? But it always helps to have more options. I have patients right now who are still enjoying the benefits of prior administration of belantamab. And I say that because they have since resolved the eye toxicity, which, by the way, in all cases with time, the eye toxicity improves. And these are patients that may have gotten a short course of treatment with belantamab and remain under excellent control right now. So I think it's always better to have more options. I don't think I would venture out to say exactly how we're going to sequence this because of the issues of resistance, but I certainly would welcome having that back in our toolkit.
Yeah, I agree. More options are better because we're all so unique, and what works for one person does not work for somebody else. So I'm glad to have as many bullets in our arsenal as possible.
Thank you. And Dr. Fonseca, we patients always appreciate it when we learn that doses can be reduced. And then when we hear dexamethasone dosing can be reduced, we just get giddy about it. And at ASH, there was a presentation that looked retrospectively at a couple of SWOG trials, S777 and S1211, that looked at patients who had lower dex dosing. Can you talk a little bit about that and what that might mean to patients going forward?
Yes, thank you. Thank you, Jack, for the question. Whenever we discuss treatments with a patient, I usually emphasize that probably the hardest part of them is going to be the dexamethasone for the reasons you know better than I do. And the story goes back now several years. As you know, it all started with a patient, Michael Katz, who said, we get too much dexamethasone. What can you do about that? Which led to the design of 4A03, which changed our paradigm that we now use dexamethasone at what we call quote unquote low doses. But I can tell you, my endocrinology friends, when they see those doses, they call us and they say, what are you doing? This is a massive dose of dexamethasone. So that was a significant change. For those in the audience who don't know, we used to use 12 days per cycle. That is 12 out of 28 days at 40 milligrams of dexamethasone. So we've moved forward, but have not completely gotten rid of it. And from what we know now is as you go on with treatment, as was shown by the studies that you mentioned, as the patient gets stabilized, it becomes increasingly clear that the long-term use of dexamethasone is not contributing much to the control of the disease. And we know for sure it's contributing to the burden of side effects. It should be noted that there's several studies that are now showing that. So the clinicians need to be cautious and need to be adjusting the doses of dexamethasone. Now, at the beginning, I think most of us feel like you need a little bit of that dexamethasone to kind of quote unquote jumpstart a good response. But even then, you can do some adjustments for doses. So in patients of more advanced age, we often will use 20 instead of 40 milligrams, or in patients who have amyloidosis, we'll do adjustments like that. But it's important to be mindful of this because patients should not be on long-term, dexamethasone 40 milligrams once a week. In fact, in general, this is not something that we should be using long-term for maintenance. It can be used short-term for, consolidation, other reasons. So the field continues to move in that direction. One patient once asked me, you always talk about len resistance, but you never say dex resistance. How do you know if it's contributing down the line? And that is one question that we need to go back and address. At the beginning of myeloma drug development, there were a lot of people who were interested in resistance to steroids, like Dr. Steve Rosen from City of Hope. And we kind of abandoned that line of thinking, but I think we need to go back and say, is there a way by which we can tell who really is going to get benefit from the addition of the steroid? So that's kind of in a nutshell what we're learning from studies like that, Jack.
Thanks so much for an incredible discussion. Our time is getting short. So if you had one key takeaway that you want patients to hear, what would it be? And we'll start with Dr. Ball.
Thank you, Cindy. And it was a delight and pleasure was all mine to be here today. I think the most exciting thing really in myeloma right now is immunotherapy to me, and the prospect of these new agents that use our immune system to kill cancer cells is really innovative and exciting. And I can't wait to understand how best we can use these strategies to provide fixed duration treatment and lead to the longest possible remission in a low or undetectable cancer state, such that our patients can have excellent quality of life.
Very good. Fixed duration. I like that. And Dr. Fonseca.
I would tell patients, and as they probably heard through our messaging, we're very excited and positively so because of the developments in myeloma. And we fully realize it would be better to meet you on social circumstances or at coffee for somewhere else. But right now, if you're diagnosed with myeloma, for many, many patients, there are options such that myeloma should not be an immediate threat. In fact, for many patients, we developed this relationship, as Dr. Ball was saying, and then we kind of track along with you for years and now for decades for some patients. It's not unusual for us to see patients now in the clinic that are well beyond the 10 years, sometimes 15, sometimes 20 plus years. Some of these patients, I am convinced, have been cured because of effective frontline therapy. But even for those who haven't, there's oftentimes options for the treatment. I know, unfortunately, this is not a reality for everyone. Sometimes myeloma is very aggressive and is very difficult to control. But please don't assume that because you're facing this diagnosis, there's an imminent threat that for sure will be life-limiting because the treatments continue to get better.
Thank you so much for your time today. We've learned so much. Thank you.
Thank you.
Thank you so much.
Well, thank you so much, Jack and Cindy, for being our incredible patient advocates and moderators tonight, helping to guide this discussion and of course, infuse some of the patient and care partner voice into this, because that's, whom we're serving. Also, to Dr. Fonseca and Dr. Ball, thank you for the work and research you both do to help move the landscape of treatment options forward in multiple myeloma. We understand just how busy the two of you are, and it means the world to witness your commitment continued to patients, to their families, even outside of the clinic and outside of research. And thanks to all of you for tuning in. We really hope that you walk away with a much better understanding of, what it is in terms of the treatment options and the clinical trials that are all happening and at a very rapid pace in the space of multiple myeloma. At the end of the day, those trials, those treatments may or may not be right for you, but it is our hope that you feel that you know more so that you can make a better decision for yourself or help your loved one make a better decision. And so on that note, we'd really, again, love to hear from all of you. Your voice matters so much to us. It really has a direct impact on what we decide to do next. And so a survey will be popping up after this window closes. It'll just take a couple minutes to fill out that survey. And if for some reason you X out of it, we will be sending a link to that survey in follow-up emails. So again, thank you so much for joining us. We hope to see you at a future The Patient Story program. I'm Stephanie Trong for The Patient Story. Take good care.